Hi, I'm Dr. Tarek Youssef. I'll be presenting to you today this case of posterior synechial, very shallow anterior chamber with a nuclear cataract. Uh, the case went very well until the lens implants, which were found to have a broken trailing haptic that needed to be explanted. So at this stage, I broke the synechia, dilated the pupil a little bit with Vitrax. Did the main wound, did the paracentesis, started the capsulorhexis in the middle using capsulorhexis forceps, completed the capsulorhexis to measure approximately about 5.5 millimeters in diameter. Would be enough to cover the optics of the intraocular lens and decrease significantly the incidence of posterior capsule opacification if you have that complete coverage on the anterior capsule lenticular surface. Did hydrodissection, hydrodelineation, nuclear rotation, and phakic emulsification will be used to remove the nucleus. I like the chopping technique to use much less power and does the job efficiently and safely. Remove the first quadrant, in the second, third quadrant, and epinucleus. Done with the phaco, and then I'll do the J cannula, which is very useful actually in cases that you don't see the complete capsule. You don't have to go with the irrigation aspiration there where you can't see, and it works really very well, efficiently and safely. In less than 10 seconds, the capsule is clean. Inflated the capsule with the inflated the capsule with the Helon, and then I'm planting the lens. And at this stage, I've found that the trailing haptic was broken, and it is too late. Now I have to expand that lens. It won't be stable enough to leave in the eye. And the problem with this case is that she has a shallow anterior chamber, and manipulations are not easily done. So that's the trailing haptic still caught in the cartridge. Usually that happens if the nurse doesn't pull the haptic out of the cartridge before she pushes the plungers in. So I'll inflate the posterior capsule, the capsular bag again, try to push the lens outside the capsule, put it in the anterior chamber so that I can pass the lens cutter out of the capsule, lens cutter into the eye, and move the intraocular lens into the capsule. So I'll open the wound a little bit, about maybe an extra 0.5 millimeter, to allow the lens cutter. It's a guillotine lens cutter. It works pretty well. It's safe and effective. So it's passed into the chamber. And now I'll move the intraocular lens into the opening of the guillotine cutter. Just I'll push the plunger to cut the lens into 2 halves. Okay, lens is cut to 2 halves. Now I'll just remove the lens cutter. remove the parts out of the cutter. Now it's the step to remove the two halves, and just inflate the anterior chamber again, protect the cornea. And the first, so it was a little bit bigger. It's like 2/5 and 3/5 cut. So that's the first one is removed, and the second one is removed, and then the other intraocular lens is injected. And this time, make sure that the haptic is out of the cartridge and the lens is implanted safely. The viscoelastic is removed from the anterior chamber again, from the anterior chamber and the capsular bag. The patient tolerated the surgery very well, but of course the first post-op day she had significant corneal edema. The wounds were hydrated. You can see the cornea is still relatively clear. So this unfortunate complication can be avoided by making sure that the trailing haptic is out of the cartridge before pushing the plunger into the injector. That's done by usually the nurse. Thank you for watching.